रहा हूँ। किसी और की क्लास तो नहीं है ना बाई चांस ख़त्म हो, क्योंकि मैं थोड़ी आवाज़ बैठी हुई, टाइम लगेगा। ये वाला IUTN पोस्टर
यू नो
हाँ। अभी टाइम नहीं, कैसे पता चलेगा स्टार्ट हो गई? अभी तो है ना।
अभी 10 मिनट है।
फिर मतलब 10 बजते से स्टार्ट कर दूँ? यहाँ IT में तो कोई नहीं आता होगा, सारे क्योंकि वैसे भी कोई मतलब नहीं है दिखता, तो यहाँ कुछ है नहीं। अटेंडेंस कैसी रहती है आपको?
वो टेलीमेडिसिन से ही है।
अच्छा, नहीं पता चलता आपको? अच्छा, ठीक है। अच्छा, लाइट चेक चल रहा है। Good morning. I am Dr. Jyoti, and today we will be discussing about postdatism and IUD. So first we will be discussing about postdatism and postterm pregnancies. So we will be covering the definitions, dating, the incidence and etiology related to postterm pregnancy, pathophysiology of postterm pregnancy, complications and the management. So the postdated pregnancies, what are the postdated pregnancies? They are the pregnancy which is lasting beyond the expected date of delivery, that is 40 weeks or 280 days beyond the LMP. Postterm pregnancy, these are the pregnancy which are extending beyond 42 weeks, that is 294 days beyond the LMP. So according to ACOG, the recommended classification regarding the period of gestation is they have divided it into early term, full term, late term and the post-term pregnancies. The early term is those pregnancy which are between 37 to 38 plus 6 weeks. Full term are those which are between 39 to 40 plus 6. Late term which are between 41 to 41 plus 6 weeks. And post-terms are those pregnancy which are extending beyond 42 weeks or 294 days from first day of LMP or more than 14 days from expected date of delivery. The term post-dated or prolonged pregnancy, they are ill-defined and should be best avoided. Better is to use the terms full term, late term or the post-term pregnancies. The incidence of post-term pregnancy ranges around 3 to 10%. However, the incidence may vary depending on whether the EDD is based on the last menstrual period or first trimester ultrasound. The prevalence also varies depending on population characteristic, like whether in the studied population what is the percentage of primary gravidas, what is the prevalence of obesity among the population, whether there is a prior history of preterm, post-term pregnancy and any genetic predisposition. Besides this, management practices also leads to differences in the prevalence, because maybe they are planned for a scheduled induction of labor. There can be differences in use of the ultrasound for pregnancy dating and elective cesarean rates. So the etiology of this is postterm pregnancy is unknown, but the most common cause which leads to the diagnosis of postterm pregnancy can be inaccurate dating, especially when the patients are not sure of their dates, there are delayed cycles or there is any problems in dating the pregnancy related to LMP, then it can lead to a diagnosis of postterm pregnancy. Besides this, in 1/3 to half of the patients, there can be due to maternal genetic variations or fetal genetic variations. There can be biological variability or can be due to environmental variations. So coming to the maternal factors, the important factors which can increase the risk of postterm pregnancy is the pre-pregnancy BMI. If the BMI is more than 25, and especially as the BMI increases, the chances of pregnancy landing up into a postterm pregnancy increases. So according to a study by Zhao et al., if the BMI is more than or equal to 35, there is 52% higher chances that if the patient is left for a spontaneous labor, there are chances of postterm pregnancy. Besides this, advanced maternal age, previous history of postterm pregnancy. So if a patient has a history of one postterm pregnancy, then the chances in subsequent pregnancy increases by about 27%. If there is a history of prior to postterm pregnancy, then this chances increases to about 40%. Besides this, sedentary habitus and nullipara with longer cervical length also contributes. The fetal factors important which can lead to postterm pregnancy are anencephaly, adrenal insufficiency and adrenal hypoplasia. And besides this, placental sulfatase enzyme deficiency is also responsible for postterm pregnancies. So very important is accurate dating. The most accurate is the first trimester ultrasound, which is done up to 13 plus 6 weeks. And when LMP and T1 scans are available, you have to determine the gestational age and EDD is to be documented. If there is no ultrasound examination before 22 weeks, which will confirm the gestational age or revises the EDD, such pregnancies are suboptimally dated. And when we have to decide the timing of delivery in these suboptimally dated pregnancy, it should be based on the best clinical estimate of the gestational age. So for dating, if the dating is accurate, it can positively affect the pregnancy outcome and can prevent undue postterm inductions. The good dating criteria includes the patient is sure of her last menstrual period, the previous menstrual cycles were regular, there was no intake of hormonal contraceptive in the previous 3 cycles, there is no history of unusual bleeding during this pregnancy, and has not conceived in a lactational amenorrhea, because again then there will be the problem when she has conceived. So for excellent dating, these 3 criteria, sure LMP, previous regular menstrual cycle, and no exposure of hormonal contraceptive, along with the corresponding uterine size and the ultrasound before 21 plus 6 weeks, if they are all corresponding, then it is called an excellent dating. So diagnosis is basically based on expected date of delivery, whether an LMP was used for calculating the EDD, or it is a USG based. If we are taking USG based, then we have to see what is the difference between the LMP and the USG gestational age. If at less than 8 weeks, if the difference between LMP and ultrasound gestational age is more than 5, then it is better to take the gestational age. If between 9 to 13, if it is more than 7, then again you have to take an ultrasound base. So in the first trimester, if the difference between LMP and the ultrasound dating is more than 5 to 7 days, then it is better to take the ultrasound EDD. However, the exceptions are the pregnancies where the dating in the IVF, where the dating date of conception and implantation is known. So there you can take with the embryo transfer. Now their ultrasound, besides first trimester ultrasound, their ultrasound first trimester, it is the CRL, that is the crown rump length, which is most accurate. CRL means that you are taking the measurement from head to bottom buttocks. So this is the CRL. So if a CRL is taken, then it in first trimester it is the most accurate for dating the pregnancy. However, if the ultrasounds are done in second and the third trimester, the parameters should not be used to change the EDD if it is already determined by the first trimester ultrasound. But it can give other ideas like about the fetal size, it can give whether the baby is average for the gestational age, or there is onset of intrauterine fetal growth restriction. So while we are doing USG parameters, so in second and third trimester, the parameters which we take is BPD and head circumference. This is BPD from the level of in a transfer section from outer to inner quadrant at the level of thalami. Then another parameter is abdominal circumference. This is the abdominal circumference. It is taken with visualization of vertebra, umbilical vein, stomach and the portal sinus. And third parameter is femur length. This is the femur length. Full length of the bone is taken perpendicular to the ultrasound beam. So all these 3 parameters, biparietal diameters, the head circumference, AC and the femur length, it will give you the gestational age. Besides this is gestational age, however, it will not be accurate if already the dating has been done with first trimester, but it will give an idea about estimated fetal weight and the growth of the fetus. Now coming to the hypothesis of onset of labor. So what happens during the onset of labor? The placenta secretes corticotropin releasing hormone, and it rises exponentially during the pregnancy. If this rise is very rapid, patient may land up into preterm delivery. If the rise is very slow, then there can be increased incidence of postterm pregnancies. These CRH, it stimulates the fetal adrenal to secrete DHEA, and this DHEA increases the estriol level. So the increase in the estriol level corresponds with the maternal CRH. So there is increase in the estriol level and there is decrease in the progesterone level. The progesterone level, which is increasing throughout the pregnancy to make the uterus in a quiescence phase, now with the onset of labor there will be decrease in the progesterone level and increase in the estriol level to mark the onset of labor. So if there is deficiency of placental sulfatase enzyme, then there will be decreased estriol level and there will be deficiency of CRH, and it will lead to postterm deliveries, postterm pregnancies. So basically with the advancement of the gestation, various changes occur. The changes occur in liquor, placenta and the fetus. So with increasing gestation, what happens to the liquor? The liquor, which is approximately 1100 ml at 36 weeks, it gradually decreases as the gestation advances, and at around 42 weeks it is around 450 ml. And from 42 weeks onwards, there is at least 33% decrease in the amniotic fluid volume per week. Besides the quantitative changes, the qualitative changes also occur. The amniotic fluid from cloudy become flaky, and then there is presence of meconium with advancing age. So there will be decrease in the liquor will be because of the decrease in the fetal renal blood flow in the postpartum pregnancy, which leads to decreased amniotic fluid production and leading to oligohydramnios. This less amniotic fluid, that is oligohydramnios, is associated with some risks, like risk of increased operative vaginal delivery or cesarean section, because there are chances of cord compression and fetal distress in cases of oligohydramnios. There will be decreased 5-minute Apgar score, increased chance NICU admissions, and the umbilical pH will be less than 7.1, that is there will be fetal acidemia. Besides the changes in liquor, there are changes in the placenta also. The placenta changes is marked by placental grading, which is an ultrasound finding. So on ultrasound, we see that the placenta is grade 0 when it is less than 18 weeks. That is, it is a smooth placenta without with uniform echogenicity. From 18 to 29 weeks, there changes occur. That is, in this, there is slight indulation in the chorionic plate, and there will be occasional parenchymal calcifications. Here also you can see. Then in grade 2, that is from 29 to 38 weeks, there will be increase in the indentations. This is the indentation, and there will be basal calcification, basal plate calcification can be seen. Then grade 3, that is more than or equal to 39 weeks, such type of placenta is called, which is also known as hypermature placenta. That is, the indentations almost reach up to the basal plate, that is the formation of cotyledons. There will be circular densities inside the placenta, and there will be marked calcification. These are the placenta where there is more chances of uteroplacental insufficiency. So these changes occur as the gestation advances. Then the postpartum pregnancies, they are associated with increased fetal and neonatal morbidity and mortality, and also maternal morbidities. So the postpartum pregnancies, as the advances, the fetus becomes larger as compared to the term babies. The chances of macrosomias are more in postpartum pregnancy, and this leads to increased incidence of labor dystocia, prolonged labor, and increased chances of shoulder dystocia because of macrosomia. This results in trauma to the pelvic floor, that is, during delivery there can be 3rd degree and 4th degree perineal tear. There are more chances of instrumental delivery, and there will be increased incidence of cesarean section. The fetal hypoxia and decreased liquor are associated with meconium aspiration syndrome, and on CTG you can find an abnormal fetal heart rate pattern. This leads to increased operative delivery. There is more chances of PPH and endometritis also. Among the fetal complication, as most of these we have already discussed, there can be antepartum, intrapartum and postpartum fetal complications. So during antepartum, the complications can be because of oligohydramnios, there can be cord compression, there will be big size baby. Because the placenta is hypermature, there will be placental insufficiency, more chances of meconium stained liquor, and there is loss of subcutaneous fat in the baby. That is, muscle wasting is there. During intrapartum, there can be chances of shoulder dystocia, cord compression, fetal asphyxia, and even stillbirth. Postpartum complications include post-maturity syndrome, meconium aspiration syndrome, increased chances of neonatal acidemia, low Apgar, and increased NICU admission. So what is post-maturity syndrome? And this all leads to perinatal morbidity and mortality. In postpartum pregnancy, there is 8-fold increase in this morbidity and mortality when the birth is occurring at beyond 42 weeks. and major causes can be infection, placental insufficiency, cord compression and meconium aspiration. So what is post-maturity syndrome? It is a post-delivery diagnosis. It occurs in about 10 to 20% of pregnancy at 42 weeks. So you can see this baby. There is a wrinkling of the skin. There is patchy and peeling of the skin. There will be muscle wasting, long thin body, unusually alert baby, and appears old and have a worried look. So this is called post-maturity syndrome. So what is the management of a postpartum pregnancy? You have to weigh the risks and the benefits, whether to induce the labor or you have to do an expectant management. Our ACOG says that expectant management with fetal surveillance should start at 41 weeks if the patient wants to go for a spontaneous labor. So management strategies include at 41, if the patient has reached 41 weeks, pregnancy is uncomplicated, then consider fetal surveillance. Membrane sweeping can be done to stimulate labor induction, onset of labor, or labor induction can be done. In complications like patient has hypertension or there is oligohydramnios, then it is better to induce labor rather than waiting. But if patient has reached 42 weeks, then the definitive is labor induction. But whatever strategy you are following beyond 41 weeks, it is very important to counsel the patient about the risks of postpartum pregnancy. And despite that, if she wants to wait for spontaneous onset of labor, then a good fetal surveillance is to be done. So what are the risks associated with expectant management it can increase maternal anxiety, it can increase the chances of prolonged labor and traumatic deliveries, more chances of cesarean sections, postpartum hemorrhage, perinatal mortality, increased risk of oligohydramnios and meconium aspiration syndrome, and the risks associated with macrosomia. The benefits are, it can increase maternal satisfaction, the more chances of patient going into spontaneous labor, it will lead to uncomplicated birth in future. There can be decreased chance of instrumental delivery if patient has gone into spontaneous labor, and there can be a shorter recovery time. However, all the risks and the benefits should be explained to the patient who are willing for expectant management at 41 weeks. So the expectant management includes fetal surveillance with daily fetal cake count. You have to explain to the patient that daily she has to notice how many fetal cake counts are there. So at least in a 12 hours time, there should be 10 movements she should perceive. You can call her for NST thrice weekly. A modified biophysical profile should be done twice weekly with AFI estimation and Doppler parameters. According to Cochrane, it included 30 RCTs in which the women were induced at 41 weeks, and they found that when they are induced at 41 weeks, rather than continuing till 42 weeks, there were fewer perinatal deaths, fewer cesarean rates. However, the operative vaginal deliveries were more. There were lesser number of NICU admissions and fewer babies were with low FCAR. So the recommendations for induction of labor in postpartum pregnancy according to ACOG, induction of labor, definite induction of labor after 42 weeks, however, can be considered at 41 weeks also. WHO says after 41 weeks of gestation, induction of labor should be planned. According to NICE also, offer induction of labor between 41 to 42 weeks and explain regarding expectant management, the risks and the benefits to the patient. And while doing an induction, a pre-induction assessment should be done. You have to counsel the patient, you have to confirm the gestational age, any contraindication for induction, confirm lie, presentation, pelvic examination should be done. And the success of induction will depend upon your Bishop's score, the parity of the patient, BMI, maternal age, and also the estimated fetal weight. So methods of induction you can start from 41 weeks, you can start with membrane stripping, or you can even go for amniotomy, or there can be induction with oxytocin, prostaglandins or misoprostol depending on the Bishop scores. The intrapartum management includes careful vigilance, keep a continuous electronic fetal monitoring, you have to watch for fetal distress and meconium stain liquor, and the amniotomy, it has dilemmas whether to do an early amniotomy or late amniotomy in a postpartum pregnancy. Both are associated with its risks and benefits. The risks of early amniotomy is कि if there is oligohydramnios, if you do an early amniotomy, there is further reduction in the amniotic fluid volume, and this will lead to the increased risk of cord compressions. Besides this, if an amniotomy is done and the labor is prolonged, then there are increased chances of chorioamnionitis or infections. But the benefit is कि if there is any meconium stain liquor, you can detect it early and timely intervention can be taken. And amniotomy reduces the duration of the labor. It also incites the labor. So it can help in further augmentation. The late amniotomy, the risk is there is risk of meconium aspiration syndrome. If there is meconium, you delay amniotomy, then there is chances that the baby may aspirate the meconium. However, the benefit is it will decrease the cord compression if there is oligo, and it decreases the chances of chorioamnionitis. So overall, if we take a postpartum pregnancy, what should be the management? So if a patient is willing to continue for a spontaneous labor, then you can give her an option that you can wait till 41 weeks, but a strict fetal surveillance is to be done. However, between 41 and 42 weeks, you should explain the patient कि if the gestation advances further, then there are increased perinatal risk of perinatal mortality and morbidity, and there is increased chances of more operative interference and postpartum complications. So this is all about postpartum pregnancy in short. Now we will be coming to intrauterine fetal demise. We will be covering the introduction part, definition, epidemiology, how to diagnose, etiology, management, and follow up for next pregnancy. So the WHO has defined fetal death as delivery of the fetus which is showing no sign of life any time during the pregnancy, that is irrespective of the period of gestation if it is not an induced termination. WHO defines stillbirth as delivery of the baby where there is no sign of life at or after 28 weeks of gestation. However, the terms like fetal death, fetal demise, stillborn, and stillbirth, they are used interchangeably, and according to ACOG, they recommend it is better to use the term stillbirth rather than fetal death. Now the stillbirth, it can occur during antepartum period or intrapartum period. Antepartum stillbirth means the death of the fetus before the onset of labor. It can be early or it can be late. The early death, it is between 22 to 28 weeks, that is when the fetus weighs 500 to 1000 gram, and late is after or more than 28 weeks. Then it can be a fresh stillbirth or it can be a macerated stillbirth. Fresh stillbirth means that the baby after death has retained for less than 12 hours and there is no sign of disintegration in the baby. Macerated means when the baby is retained, dead fetus is retained for more than 12 hours and there is sign of disintegration in the baby, like maceration, signs of maceration, peeling skin, congestion, and all these. Then intrapartum stillbirth is after the onset of labor. So RCOG defines stillbirth as baby delivered with no signs of life, known to have died after 24 completed weeks. Intrauterine fetal death is, it refers to the babies with no sign of life in utero. So if it is died in utero, it is intrauterine fetal death. So approximately 2.6 million stillbirths, they occur globally, and more than 7,000 deaths of baby occur in a day. Most of this occurs 50% in intrapartum period, and 3/4 of these all stillbirths, they occur in South Asia and Sub-Saharan Africa. However, the number of the stillbirths over a period have declined by 19.4%, that is an annual reduction rate is about 2%, but still in India the stillbirth rate is 22 per 1000 births. Now, what is the etiology for stillbirth? It is a multifactorial etiology which involves both maternal factors, placental, fetal, factors. Besides this, infections of the mother and the fetus and unexplained causes. So coming to the maternal causes, the important causes can be related to age of the mother, very young age group or an advanced age group. Both are risk factors. Besides this, previous history of stillbirth. If mother has any comorbid conditions like patient is hypertensive, has diabetes mellitus, has history of thyroid disorders, any form of renal disease, or patient has a substance abuse history. Besides this, if there are antiphospholipid antibody syndrome or autoimmune disorders in the mother, there is intrahepatic cholestasis of pregnancy, then it all increases the risk of stillbirth. The fetal causes include platelet or red cell alloimmunization. There can be, in about 15% cases, there can be because of congenital malformations or chromosomal or genetic abnormalities. There can be complications related to multiple gestation like twin-to-twin transfusion syndrome or TRAP, or it can be due to non-immune fetal hydrops or due to fetal growth restriction. These are all causes, fetal causes, which can increases the risk of stillbirth during a pregnancy. Besides this, there are placental causes, like if there is placental abruption or placenta previa. So there is a antepartum hemorrhage. If there is antepartum hemorrhage, then it increases. If it is massive hemorrhage, then it can increase the chances of stillbirth. Then if there is uteroplacental insufficiency in cases of a fetal growth restricted pregnancy or a postpartum pregnancy which leads to hypermature placenta, or patient is severe preeclampsia, then these all conditions can lead to uteroplacental insufficiency and sudden stillbirth. Then there can be some placental pathology like chronic velitis, or there is massive perivillous fibrin deposition in the placenta which hampers in the function, can lead to increased chances of stillbirth. Besides this, umbilical cord complication like filamentous insertion or any other abnormality of the umbilical cord can lead to increased chance of stillbirth. Besides this, the infections, whether it can be a bacterial, viral or parasitic infection, can increase the chances. Among the bacterial important ones are Listeria, Treponema, Group B, Streptococci and E. coli. Among viral, there are the CMVs, Parvovirus, Enterovirus, HCV, HSV, HIV, Rubella, and among parasitic are the Toxoplasmosis and the malaria. So there can be placental transmission of the infection from mother to fetus, which can increase the risk of stillbirth. So the placental transfer can be of CMV, syphilis, parvovirus, rubella, toxoplasma, HSV, etc. And there can be ascending infections also like E. coli or Klebsiella and this. So it is very important during pregnancy to treat infections, because these infections are not only causes the maternal morbidity but increases the chances of fetal morbidity and mortality also. Now in about 25 to 60% cases, the cause of stillbirth is unexplained. That is, it is not attributed to any identifiable fetal, maternal or placental causes. And mostly these unexplained stillbirths, they occur at term. So intrapartum causes of stillbirth, these are the antepartum causes. Then there can be intrapartum causes of stillbirth also, that is the fetus died during the onset of labor. So what are the common causes which can lead to death of a fetus during labor? So one important thing is cord prolapse, or there is a vasa previa, or there is massive placental abruption which can lead to sudden IUDs. Then if the patient has gone into obstructed labor, or there is trauma during delivery to the fetus. Malpresentations can also increase risks of stillbirth. If in cases of previous cesarean, there is sudden uterine rupture during labor. The infections, especially the chorioamnionitis, patient has leaked and there is leaking for more than 18 hours leading to chorioamnionitis, and infection of the uterus and the baby can lead to sudden death during labor. Fetal distress, and sometimes there is unspecified cause. Maybe the cause you cannot find the cause, what caused the death of the baby. Now, what will be the presentation of patient with intrauterine fetal death? So, most of the times what happens ki when the patient comes to us in OPD, she will complain that she is not perceiving fetal movement, but it is a very subjective finding. Sometimes because of work or they are busy, they are unable to perceive the movements. So it is not called a characteristic feature that if there is a patient is saying that she is not perceiving a fetal movement, that means definitely the fetus has died. Sometimes it can be asymptomatic, diagnosed by physician either during a routine antenatal checkup, that is patient comes to you for a routine antenatal checkup, you put a stethoscope to listen the fetal heart and you are unable to hear, or patient has come for a routine ultrasound checkup and on ultrasound you find that there is no cardiac activity. So either she can present with symptom or she can be asymptomatic. The important signs which can give you a diagnosis that maybe the fetus is dead is if unable to feel the fetal movements, fetal heart sound is not audible, the uterine tone is diminished or increased, or there is gradual retrogression of height of the uterus. Suppose the patient has come to you 1 month prior and 1 month back also there is the same fetal height, then either you can suspect IUGR or you can suspect that there can be a fetal demise. So, how to diagnose? If you think you can auscultate, if you are not hearing with the stethoscope and you can auscultate with CTG, then you can be misguided, because uterine shuffle will also give you a feeling that it is a fetal heart sound. So you cannot rely on CTG, you cannot rely on mother's finding, because even in cases of IUD, patient may perceive passive fetal movements. She may say ki no, I am perceiving fetal movements. So the correct diagnosis or the accurate diagnosis is made only on a real-time ultrasonography. So by ultrasound you can detect the absent fetal cardiac activity. So definite diagnosis is made only on ultrasound. Even if on stethoscope you are unable to hear, then also you have to confirm your finding with ultrasound. So for ultrasound, what else it can give you inference besides that the fetal heart and movements are absent, it can give you an idea about fetal lie-in presentation, if there is an hydroamnios, polyhydroamnios, if there are features of fetal hydropic changes in the baby, or there is a macerated baby, that is there is overlapping of skull bones and skin edema. Then it can also give you an idea about placental location, and also if there is presence of any retroplacental clot. So basically ultrasound can give you an idea if there is some cause for IUD. Suppose if there is you find an abruption or a massive retroplacental clot, maybe this was the cause for IUD. If there is fetal hydrops, especially in cases of alloimmunization or non-hydropic features, maybe this may be the cause. So ultrasound can give you various type of informations in such cases. Besides this, though we don't routinely do X-rays, but there are some important signs which corroborate with IUD on X-ray. So one is Robert sign, that is when on X-ray gas shadows are seen in the large vessels. It usually occurs after 12 hours of fetal death. Spalding sign, that is the collapsed skull bones is seen after 7 days of death. Wall sign, which is hyperflexion or the hyperextension of the fetal spine, and the helix sign is gas in the umbilical arteries and ribs overcrowding on X-ray, which here you can see. ठीक है. Now important thing is कि once you know that this patient has IUD, now important is how to break the news. ऐसे नहीं होता कि मतलब पेशेंट आई, आप यू हर्ड द फीटल हार्ट साउंड एंड यू से कि लुक हेयर आई एम अनेबल टू हियर द फीटल हार्ट साउंड, इट मीन्स द fetus is dead, because you cannot directly break the news. Important thing is first you should confirm the diagnosis. If you are unable to hear with the stethoscope, first confirm with ultrasound and then you think how to break the news. Important thing is, if it is a heavy OPD, don't just say in front of all the patients कि your baby is dead. You have to take her to a private space, call the relatives, be prepared to give a mental counseling and support. You can call the counselor also. Family member are the best support, so it is better to you break the news slowly in an unhurried manner in presence of the family members who can support the patient when you break the news. So important not only is to diagnose intrauterine fetal death, but it is also important how you break the news and how you counsel the patient. Beside this, you have to explain them about what is the further process of investigations for the cause of IUD, and you can also discuss with them the possibility of fetal autopsy to find a cause if the cause is not known. So the parent should be made aware that sometimes no specific cause can be found in almost half of the stillbirths, and when a cause is found, it is important basically to find a cause because it can affect in the future pregnancies, if it is a cause that can reoccur in future pregnancies. And also an abnormal test result is not necessarily always related to intrauterine death. An abnormal blood test or should be correlated with the postmortem examination also. And you also tell them that sometimes further investigations are also necessary to confirm the cause of fetal death. So while you are approaching such a case, important is to take a detailed present pregnancy history. That is, what is the age of the patient, at what gestation the IUD has occurred, whether there is any associated comorbidity in the patient like hypertension, diabetes, then any history of cholestasis, that is ICP, any history of preterm rupture of membranes, any history of abdominal trauma. Then take a good obstetric history, that whether in the previous pregnancies, whether it is a first pregnancy or previously she has had baby with congenital anomaly or had a baby with FGR, or previous history of IUD, previous history of gestational hypertension or placental abruption in previous pregnancy, or there is history of recurrent abortions. Then assess the medical condition of the patient, whether she is having diabetes, hypertension, any thrombophilias, APLA syndrome, history of SLE or epilepsy, patient has anemia, heart disease or thyroid disorder. So you have to thoroughly examine the case to look for any cause related to stillbirth, because once you have diagnosed that yes, it is an intrauterine fetal demise, but important is if you can find a cause, because if you can find a cause, you can prevent same occurrence in her subsequent pregnancies. So besides this, family history is also important. If there is any history of congenital anomalies, recurrent abortions, history of venous thromboembolism or abnormal karyotype, any hereditary condition which can occur in this case also. So while you are working in a patient with IUD, important is see for her general well-being and her mental status, check her vitals, do a systemic examination to find out any cause, then a per speculum or per vaginal examination. Besides this, you have to do investigations for maternal well-being, do a blood group, complete blood count, LFT, renal function, kidney function, thyroid profile and sugar also. Besides this, coagulation profile and DIC profile should be done. Do a routine for albumin, sugar and ketones, and do ultrasound to check fetal presentation, lie, placenta position and also any retroplacental clot. So for evaluation of late IUD, the recommended tests are basically for maternal well-being, which we have already discussed, that you have to do a complete blood profile and check for any cause. Now important thing is whether to induce this patient or to wait for spontaneous progress of labor. So you can offer both options to the patient. You have to tell her that in 80% cases, spontaneous onset of labor occurs within 2 weeks. However, 10% may remain undelivered for more than 3 weeks. And delivery should not be delayed if there is rupture of membranes, abruption, you suspect abruption, patient has severe preeclampsia or there are signs of sepsis. If these are not present and mother chooses for expectant management, then you have to do a periodic follow-up to assess for temperature, bleeding, pain abdomen, labor and emotional status of the mother. Do a CBC and coagulation profile twice a week. However, you have to tell the patient कि if she will delay and will wait for a spontaneous progress of labor, this can reduce the value of a post-mortem examination if they are willing to find out a cause, if the cause is not known, because then the appearance of baby may be deteriorate and the cause may not be found. Let the patient take the call and decide. So in about 10% there may be chances of maternal DIC which can set in if the fetal death has occurred for more than 4 weeks. So how to plan induction? So according to RCOG, planning should be done based on whether it is a scarred uterus or unscarred uterus. If it is an unscarred uterus, then mifepristone and misoprostol are the first line of management for induction. Misoprostol should be used by vaginal route because it has more efficacy as compared to the oral route because there is local absorption, and it should be preferred to prostaglandin E2. However, if there is any contraindication, then obviously Surviprime gel can be used, or depending on the bishops, even oxytocin can be used. But if misoprostol is used and the gestation is less than 26 weeks, then the dose can be used as 100 micrograms 6 hourly. If it is more than 27 weeks, then 25 to 50 microgram 4 hourly can be used up to 24 hours. But if it is a scarred uterus, then a good option is to use mifepristone alone, 200 microgram TDS for 48 hours, and in about 63% cases labor induction starts. However, misoprostol should not be used because of the risk of rupture. Prostaglandin E2 can be used, however, it is also not associated without risk. So you have to look into the risk-benefit ratio. Then cesarean delivery should only be done for maternal indications, and consider patient's health, obstetrician and her preferences also. So intrapartum management in a case with intrauterine fetal death include if there is any suspicion of sepsis is there, then you should start antibiotic. However, routine prophylaxis is not recommended. Pain management you can give. However, if the patient wants a regional anesthesia, then rule out first any sort of infection or DIC. Important is to give her emotional support, and after delivery try to avoid keeping her with mothers with baby because it will lead to more emotional depression. So after delivery, allow the patient and family to see and hold the baby. Give them opportunity to create keepsakes if they want. Grief counseling should be done. Lactation suppression should be advised, and also contraception should be advised because if the cause is not known or whether the cause is known, it is better to avoid pregnancy too early. So contraceptive method should be advised to such patients. Then what can be the complications of intrauterine death during pregnancy? It can lead to infections, coagulopathy, psychological upset, RH isoimmunization in RH negative patient. There may be requirement of surgical intervention. During labor, there can be uterine inertia, more chances of retained placenta, PPH, rupture uterus, especially in cases of patient going into obstructed labor or with previous cesarean if we are very aggressive. So the aggressive mode should not be used. Once IUD has already been detected, one should go slow. However, the lab parameters should be taken into account, whether there is DIC has set in or not, there is increased risk of infection or not. This all should be taken into account. Now, how can we prevent recurrent stillbirths? So what strategies we should adopt? So important is preconceptional counseling, review all records, discuss possible etiologies, optimize maternal condition and change potentially modifiable factors. So for management of subsequent pregnancy, a preconceptional counseling is important to discuss about what should be the follow-ups in first, second and third trimester and delivery. So a detailed in preconceptional counseling, a detailed medical and obstetric history should be taken. Evaluation should be done for previous stillbirth. If determine if there is any recurring risk, discuss other obstetrical complications. If patient has a history of smoking or alcohol or substance abuse, ask her to immediately stop. If she is obese, advise her weight loss. If there is any family genetic condition, then genetic counseling should be advised and should be sorted in preconception period, so that what all things may be required if patient gets pregnant, and definitely support and reassure the patient. Now if she is pregnant, then during first trimester, first do a dating scan, do a dual marker and an anti-NB scan, do a diabetic screen, APLA workup if there are history of recurrent abortions, and support and reassurance. In second trimester, again level 2 scan should be done at around 18 to 20 weeks, or a quadruple screen can be asked and support reassure the patient. In third trimester, rule out FGR by doing ultrasound. Advise patient to do a daily fetal kick count starting from 28 weeks and antepartum fetal surveillance starting from 32 weeks onwards, or 1 to 2 weeks prior than the gestational age of previous stillbirth. So before if the previous stillbirth is 32 weeks, then start the fetal surveillance from 30 weeks. Then delivery, if no risk factors there, then induction should be done at 39 weeks, or if there is any medical comorbidity or any induction for early termination, then that should be considered. Then according to WHO, every baby counts. So it is very important to review your stillbirth and neonatal deaths. So there is a performer of a stillbirth neonatal death. It should be filled, and important thing is कि while you are filling, maybe you can encounter with some modifiable or some preventable causes, and which you know that these were the causes and these should be avoided in subsequent pregnancy. So it is very important to fill a stillbirth form. WHO has advised every newborn action plan, which says that there should be no preventable deaths of newborn or stillbirths, and by 2030 the target should be 12 per 1000 births. India has also launched in 2014 a India newborn action plan, which says that ending preventable newborn deaths and stillbirths by 2030. The goal is single digit neonatal mortality and stillbirth rates by 2030. And there are 6 pillars of intervention, that is preconceptional and antenatal care, care during labor and childbirth, immediate newborn care, care of healthy newborn, care of a small and sick newborn, and care beyond newborn survival, which means seeing for any fetal abnormality or defects in the baby. So with this, I would like to thank you that we have covered postterm and the IUD in this lecture. But important thing is, whenever you are dealing with any of this, then it is very important to approach the case, study the case history, look for the factors which can be modified and which can be, and if any cause is found, then it should be dealt with. So if you have any questions, you can put your questions in the chat box. Thank you.